Hello and welcome to your online lecture for elbow pathologies. I'm pretty excited to be discussing the elbow joint. So what I'm going to do is break this down into two online lectures. The first one will really just be the kind of functional anatomy of the elbow joint, and then the second lecture will then be all of the pathologies that you might encounter as an evidence-based practitioner moving into the field of athletic training. So let's go ahead and hop into the anatomy of the elbow joint. I'm going to be moving my face around just a little bit so it's not covering the titles. I thought it was important to give you an x-ray image of what the elbow joint actually looks like, but then I also brought the elbow joint with me, so I kind of want to orient you all. This is the anterior aspect of the elbow joint as if we were in a supinated position, right? So as we're looking at this, this is the most distal portion of the humerus, and then we have the most proximal portion of the radius, so it's going to represent the lateral side of the forearm if we are in an anatomical position. And then this will represent the most medial side. This is going to be the ulna. I'll point to it here. This is going to be the ulna bone. It's going to represent the most medial side of the elbow, or the pinky side, right? So as we look at this as a whole, anatomically, with all muscles transected and reflected and dissected away, and all ligamentous structures taken away, what we see here is the bony architecture of the elbow. And one of the things that I find fascinating about the elbow joint is that it is the midway point between the glenohumeral joint and the most distal joint in the human body, at least in the upper extremity, the wrist. And so we can see that while maybe the elbow doesn't get a whole bunch of credit for what it does, it is a major supporter to the glenohumeral joint. In fact, oftentimes if we see inefficiencies in the glenohumeral joint, oftentimes those inefficiencies might be transmitted to the elbow joint and may cause further injury to the elbow joint, particularly in patients who participate in overhead sports. But let's step back just a little bit just to say that we have three distinct joints, right? We have three distinct bones that make up the elbow joint. The first bone is going to be the most distal portion of the humerus, right? Then we have the ulna medially and the radius laterally. And so those are the three bones that will make up the elbow joint. And so then obviously we probably have three joints that are associated with those three bones. The first bone or joint that you'll see, which is listed there, is going to be the humeral radial joint. And so we can see that that represents the articulation between the distal humerus and the radius. In particular, if you're looking at this image on the slide, right, so if we were to come down here, it represents the articulation between the capitulum, right, the capitulum of the humerus, and the radial head or proximal portion of the radial head, right? So that these two anatomical structures, the distal humerus or capitulum and the radial head, make up what we know as the humeral radial joint. On the medial side of the body, we have the humeral ulnar joint, which is going to represent the articulation between the trochlea. So if we were looking at that here, the trochlea here, and then the most proximal portion of the ulna, right? And so what I'm going to do now is take that elbow into a flexion moment, and I'm going to turn it this way so y'all can see. You can see how the radius will glide on the capitulum, see it there, and how the ulna here is going to be gliding on that trochlea, right? And when we move into a full flexion moment, hopefully you can see that. If not, I'll show you in class. When we move into a full flexion moment, there are these notches in the humerus, one here, and then there's one here. Those notches are intentional, right? They have to receive the radial head, right, and the olecranon. And those notches, we have a radial notch, which is great. And what do you think that radial notch is actually going to do? Anyone want to tell me? Great, it's going to receive the head of the radius. You can see that there. So it's going to receive the head of the radius here. And then we have a coronoid fossa. So I'm going to show you that coronoid fossa. It's right here. So what is that coronoid fossa going to do? What's that coronoid fossa going to do? Great, it's going to receive the ulna and allow that elbow to move into a flexion moment. So if I could kind of back up a little bit. So far we've talked about two joints. The humeral radial joint, which represents the articulation between the capitulum of the humerus and the radial head. Then we also have the what we call as humeral ulnar joint, which represents the articulation of the humerus with the actual ulna. we know that we have the ulna, which articulates with the trochlea here. But then as we move into flexion moments, we have to have these kind of fossas or cavities that kind of receive the humeral head in the ulna. So on the radial side of the elbow, that fossa is known as a radial kind of notch or radial fossa. And then on the ulnar side, we know this as the coronoid fossa or coronoid notch, right? And so those, if those were not on the humerus, right? So if those were not on the humerus, right? We got that radial notch right here, that coronoid fossa right here, then we wouldn't have as much elbow flexion because those bones would have nowhere to actually go. Now I've talked about the humeral ulnar joint. I've talked about the radial, humeral radial joint, and now what we need to talk about is the radial ulnar joint. So that represents the articulation between the head of the radius and the proximal ulna. And so why is this important? I'm going to tell you. So when we think about motions at the elbow joint, first and foremost, the elbow joint is a hinge joint. So think of it like a door, right? Kind of like the knee joint, essentially. Flexion and extension moments, and we have bony blocks each way. In an extension moment, we can see posteriorly the olecranon process of the ulna. Can you see that there? Is going to be the stopping point in an extension moment, which is why most often we have about 0 degrees of extension moment. Now, there are, of course, patients who are hyperlax, right, and might have more hyperextension moments than most, okay? And then we can move into a flexion moment, right? And that flexion moment is going to happen at two different joints. First and foremost, at the humeral radial joint. We can see the radial head kind of gliding over the capitulum, right? Also at the humeral ulnar joint, we can see the ulna gliding across the trochlea in the trochlear groove. And so we get flexion moments, right? But when we look at the third joint, which we haven't talked a whole bunch about, the radial ulnar joint, we have to think about what that means. So it's the relationship or articulation between the most medial portion of the radial head and the lunar notch of the ulna. Okay, so what motion occurs at the radial ulnar joint? It's kind of tricky, right? It's not a flexion extension moment or a sagittal plane motion. It's going to be a transverse plane motion. So are you ready for this? I'll kind of take a step back. It's going to be pronation and supination. What we most often see is that radial head is flat and round, and so guess what it's going to do? It's going to spin or roll over the ulna in a pronated moment and then roll back into a parallel position in a supinated motion. So motions that occur at the radial ulnar joint are going to be pronation, supination motions. Motions that occur at the humeral radial and humeral ulnar joint are going to be flexion and extension moments. And these joints are extremely important, right? They are responsible for creating motion at the elbow, particularly flexion and extension, or of course our supination and pronation moments. And so these are the three joints. What we most often see in a setting is a couple of things happening. Most often, if you're looking at it from this perspective, we typically will see what kind of forces? Compressional or stretch forces on the medial side of the elbow in most sports. Good. We're going to see most often we're going to see stretch forces that occur on the medial side of the elbow, which means what for that humeral radial joint? Compressional or stretch kind of moments. What do you think? Great. So most often if we see injuries to the humeral radial joint, most often they're from compression moments, either high valgus loads, stress loads that cause so much compression that we see kind of a degradation or a breaking down of that humeral radial joint. So those are the three joints of the elbow, and then the three bones that most often work to create the elbow joint. And so We can see that here in this image, but I hope that I've at least explained a little bit better with this anatomical structure. As we move forward, there are things that we have to consider about the elbow as it relates to elbow injuries. What we know about most elbow pathologies, right, is that they most often occur in patients who participate in upper head or overhead sports, right? I think that's common sense, particularly those patients that are participating in overhead sports that require the elbow to move through large ranges of motion at like a high velocity. And we can kind of see two sports on this slide. In the lower left hand corner of the slide, we can see a tennis athlete particularly winding back either for a spike of a ball or a serve. But most often when we're thinking about elbow pathologies, which sport are we thinking about? Right, it's going to be youth baseball, and then obviously the MLB most often. So we have to be very, very, what's the right word, particular when we're assessing our overhead athletes as we start to look at the elbow. One thing that we know about the elbow, again, it's really a happy joint until we have inefficiencies either at the wrist and or at the shoulder. So in other words, if we have a shoulder that maybe has multi-directional instability, those forces can be transmitted down to the elbow, and so you can start to see more forces occurring on the medial side of the elbow for the UCL ligament, or compressional forces occurring at that humeral radial joint. And so it becomes important to, when you have a patient who comes into your clinic with an elbow pathology, to not only assess the elbow, but then also to look at the joint proximal and distal to that, right? So to look at that glenohumeral joint, or to look at the wrist and the hand, to see if in fact there is dysfunction at one of those two joints actually causing the pathology that you see sitting in front of you in the clinical setting. So as we've already discussed, we've talked really a bunch about the bony anatomy of the elbow joint, but let's talk about other structures that really make the elbow one of the most stable joints in the body. So first and foremost, it's the bony anatomy, right? We have the humerus, we have the radius, we have the ulna, and then we have the three different joints that come together, right, to create really a strong and stable hinge joint, right? What we know about the elbow joint is it's very rare that it's dislocated. It's almost like the hip in that regard, that when we do have a dislocation, it's pretty catastrophic and it's a medical emergency. But 50% of the stability in the elbow joint comes from the bony articulation, and then the other 50% comes from really true, when we look at the next slide, ligamentous stability. Now, yes, we have these dynamic structures which kind of cross over the elbow joint to supply the wrist, for example, or to supply elbow motion, but the dynamic structures really don't provide the bulk of the stability at the elbow joint. So this is one of the first joints where we're starting to see it really relies heavily on bony architecture and ligamentous architecture. But that's scary, right? If we think about the common injuries that occur to the elbow joint, most often are to which structure? Is it bony, is it ligament, or is it muscle? What do you all think? Great. Hopefully you said ligaments, right? Like we know that, I don't know, 60 to 70% of pathologies that are reported in the elbow joint typically are to the UCL because of the stretch or shearing motion that is often occurring in those overhead sports. So if a lot of the injuries are occurring and they're occurring to the ligamentous structures, and the ligamentous structures make up about 50% of joint stability, what happens when we have a ligamentous injury? Great. What I hope you said is, Dr. Cosby, if we have damage to the ligaments and they make up 50% of the stability, then we're going to have an unstable elbow. Now, take me a bit further here, right? And let's think, okay, if I have an unstable elbow, what does that mean for the glenohumeral joint and the wrist joint? Mainly the glenohumeral joint. Is it a possibility that it could slow down the speed of a pitch, the length of a throw? So there are dire consequences for injury to the two types of structures that provide stability for both the joint proximal and the joint distal to that. Now, if we're thinking normal anatomy, one of the interesting things about the elbow joint is that it sits at about a 10 or 15 degree projection away from the midline. So in other words, if I were to kind of stand up in this position, and then I'm going to put my camera here, hopefully you can see that. If I were to stand here and really truly just be in an anatomical position, you can kind of see the angle. In other words, my forearm isn't touching my leg no matter how much I want to. In fact, it sits out at an angle. Hopefully you all can see that. That angle is larger in females than it is males. And what's the anatomical reason for that? Think back to the pelvis lecture in lower extremity. What did we say about the anatomical makeup of the pelvis for a female versus a male? Right, we said that the anatomical makeup is that the pelvis is a little bit wider, right? And that's to obviously to set the female up if she chooses to deliver, right, or for pregnancy. And so in this instance, our carrying angle is going to be a lot larger, because if you look at the carrying angle, one of the things that we can see is the angle typically will start right at the iliac crest. So traditionally speaking, the carrying angle in females is going to be about 10 to 15 degrees, and then in males it's going to be about 5 degrees, give or take. Anything outside of that, and you're concerned, right? Because if you think about carrying angle, it increases the valgus load just naturally on the UCL, and so those that have higher valgus angles or carrying angles typically have more stress on the medial side of the elbow, more stress on those stabilizing ligaments. And so then there's concern there, right? Now, we have natural carrying angles, and then what we know about most sports, and I'll go back a slide as I talk through that last bullet point, is that a lot of the sports in the upper extremity will place stress on the actual elbow joint, right? And we can see that here in this serve, maybe. We can see that here as the pitcher winds up into the cocking phase to get ready to pitch, right? We can see that maybe that's a shortstop person or a pitcher, I don't know. But you can see that valgus load being placed on the elbow as they wind up to throw a very fast throw. And so what we can say without a doubt is that patients or clients who come into us and participate in upper extremity dominant sports, particularly overhead dominant sports, there's just an increased amount of stress and force being applied to the elbow joint, right? That includes volleyball, for example. That includes tennis. It most certainly includes baseball, and even your softball athletes, those that play in the outfield, will most often suffer from increased stressors on the medial side of the elbow, right? Which goes with this whole valgus overload with throwing. In other words, if we go back a slide, we can see that there's a massive amount of valgus overload on that elbow, right? And same thing here. That's a massive amount of valgus overload or stretch, which means what for the humeral radial joint? It's being compressed, right? And what's interesting about this concept, right? This concept of there's a valgus load at the elbow, which is a stress, and we're so in tune to assess that. But oftentimes, the culprit is actually damage to the humeral radial joint as a result of the amount of stretch forces on the medial side. So as you're evaluating the elbow, make sure you're looking at both the medial side and the lateral side of the elbow. And here's just another way to look at this, right? We can see that this is a lot of valgus force, and so we have a lot of stretch on the medial side of that elbow. But then as we look at it from a different perspective, we're looking at the lateral side, we can see that humeral radial joint is just being compressed, right? And so when you have a patient who has participated, let's say in baseball or volleyball or tennis for a very long time since youth, oftentimes you're really most often not concerned with MCL pathologies. Yes, that's going to happen, but what you start to see is like an osteochondritis or the development of osteoarthritis in the humeral radial joint, which actually plagues the athlete more. And so it becomes important for us to kind of talk through what does it mean when we have a patient who maybe has an increase in laxity on the medial side. What things do we need to do to kind of strengthen the stabilizers, the dynamic stabilizers, to take the load off of the lateral side of the elbow. So as we look at this image, again, what we're thinking is a pitcher or a thrower or a tennis athlete or a volleyball striker, as they go to wind up, we get massive tension on the MCL, right? And that's intuitive, and that's what we've been taught to think. But then as we look at that lateral side, those repetitive forces, those redundant valgus forces on the medial side of the elbow most often contribute to compression of the humeral radial joint, which over time leads to an osteoarthritis development. So that's probably more of a long-term consequence, right? Think OA, and it's something that is very difficult to heal from. This we can kind of replace, right? We can do a Tommy John surgery, but when you have damage to cartilage and you have damage to bone, we all know that cartilage is very hard to regenerate. And so as you start thinking about this, as you get ready to work with overhead athletes, in particular overhead athletes who who either strike at a high velocity or throw at a high velocity, one of the things that you want to consider is how can you unload the humeral radial joint because there's so many valgus forces being applied to that elbow joint. So let's talk through this. There's this natural progression or natural history of elbow injury in overhead athletes, right? And we expect that this is going to be the case because when athletes throw in particular overhead, there is, if we go back to this slide here, there is tension that's going to be placed on the MCL, which can lead to compression of the lateral structures. So as we think through the natural history and the natural progression of elbow injury in overhead athletes, one of the things that you have to think about is we can predict that our patients are going to present to us with UCL laxity. We can predict that over time, if we don't treat or strengthen the dynamic stabilizers, we can predict that, in fact, not only will they suffer from this valgus extension overload syndrome, that they'll also suffer from some type of humeral radial pathologies. And so when we think about the etiology of this, most often it's from a massive amount of valgus load in the late cocking phase. And then essentially what happens is I cock, I get massive overload, and then I throw the ball, and what happens to my elbow? I'm in this rapid extension, right, as I release. And so what we see is we have three kind of major forces being applied at the elbow. First and foremost, we have the valgus load, right? We know this. We have the valgus load on the MCL, number one. Number two, because we have a valgus load, we have compression on the humeral radial joint, which we've talked about, or the radial capitellar joint, depending on who you ask, right? And this can lead to, we talked about osteoarthritis, it can lead to loose bodies, right? All of those things. And then the next thing that we have on the posterior side, so valgus load, we get valgus stress, we get compression on that lateral side, but as we follow through and release, we get this extension mechanism, right? So let's do it this way, right? We're here, we're flex, and then we throw and we have this extension mechanism. So you kind of get these kind of shearing forces on the posterior aspect of the elbow, particularly on the olecranon. And so what you can see here is that over time, you'll start to see the buildup of osteophytes because it keeps butting up against the fossa of the humerus. And so three different things to consider as you're thinking about the throwing athlete, right? Obviously the valgus load here, right? On the medial side, we'll have to treat that. And then you have the compression load, right, on the humeral radial joint. But then as they move from that flex position and they're throwing, there's this extension mechanism which is causing the olecranon to make contact with the humerus, increasing the risk for developing osteophytes. And the hard thing with osteophytes when that develops, to be quite honest, is that if you think about an osteophyte, remember it's a bony outgrowth like an exostosis, and so then it starts to limit their ability to move into an extension moment, right? Which we know in the late phase of throwing, not here, but in order to get really good velocity, we have to move into an extension moment. If we can't do that, then we lose miles per hour on our pitches, for example. So I guess what I'm trying to say is I kind of want to open your mind to the potential of injuries that can occur in overhead throwing athletes. And I think we have this kind of tunnel vision lens on when we think about throwing athletes. MCL, Tommy John. But there are two other structures that are being compromised in that process. The lateral side of the elbow joint and then the posterior side. So make sure you're being, what's the right word? Integrative and holistic in your treatment of the elbow when you have a throwing patient or an overhead patient come into your clinic. So I think I just said this, but let me say it a different way. I really want y'all to start thinking outside of the box, right? We can think inside of the box all day long. We're going to see muscle tendon pathologies. We're going to see ligamentous injuries. But some of the outside of the box things really relate to the elbow's relationship to the shoulder and the wrist. So a patient who comes in and is reporting maybe radiculopathy, right, into the elbow. Is it coming from the stretch or the tension? Or is it actually coming from maybe like a C5 through T1 nerve root pathology, right? That's thinking outside of the box. Does the patient have maybe a nerve entrapment or a disc herniation in the cervical spine that's impacting the elbow's ability to do what it's supposed to do? So all that to say, as you start thinking through differential diagnoses, it becomes important to really think holistically about what things can cause an elbow pathology. We know that tension here can cause compression here, can lead to osteophyte development here. But what about the cervical spine? Is it possible that we could have a cervical spine pathology that impacts the elbow's ability to, number one, support the glenohumeral joint, and then also help the wrist with its fine motor movements, right? And that's one of the beauties of the elbow joint is, look, I can't brush my teeth. I can't scratch my head, right? I can't pick up my backpack or pick up a spoon to eat. My wrist and hand cannot do that without the elbow, right? It would almost be impossible. Now, there are surgeries, right? We do realize that there are patients who may be born with shorter elbows, or maybe some other bony abnormality where you can attach the hand to it. But again, the elbow is the driver of movement, both in the wrist and hand, most importantly for fine motor movements, but then also helps drive movement at the glenohumeral joint as well. So we talked a lot about the kind of bony architecture, and we said that makes up 50% of the stability in the elbow joint. And then the other 50% really was accredited to the ligaments of the elbow joint. So I'm actually going to start here in this bottom image first, because these are probably two of the most important ligaments of the elbow joint. So on the bottom half, you all have usually heard of the ulnar collateral ligament. What I'm hoping is that we go a little bit further in our class today and actually break the ulnar collateral ligament down into three kind of bundles. The first bundle is what we call as the anterior bundle of the ulnar collateral ligament. This anterior bundle of the UCL attaches to the medial epicondyle, which you've learned, and then comes down and attaches right here on the ulna on what we call as the coronoid process, right? And so it's this aspect, the anterior bundle of the UCL, that is most often responsible for resisting valgus loads or valgus forces at the elbow joint, right? That's the one that's most commonly injured in valgus loads. But it is also broken down into two other bundles. The bottom bundle here, known as the transverse bundle, attaches to the coronoid process and then has like a posterior attachment to the olecranon process, as you can see here. And then last but not least, the posterior bundle, which has an attachment to the medial epicondyle, and then comes down and attaches onto the olecranon. So we can see kind of this triangular fashion or shape of the UCL, knowing that the anterior bundle is the bundle that is most often compromised in a valgus load to the elbow. So that is what I wanted to add there. The next ligament on this image is the annular ligament. The annular ligament is kind of the ligament that kind of wraps itself around the radial head. Its major role is to kind of form the connecting point between the radial ulnar joint itself. It's what's responsible, like if you look at it in an anatomic model, it literally wraps itself around the radial head, and it creates kind of this soft-like structure for that radial head. Remember, we said it's going to kind of roll as we supinate and pronate. It creates kind of that space for the radial head to do that. And then on the upper image, what we have is the radial collateral ligament. The radial collateral ligament is one bundle in particular. It's this bundle here. So as you can see, it's going to have an attachment to the lateral epicondyle and then come down and attach to the most proximal portion of the radius. And so its major role is to prevent varus forces at the elbow joint. So all in all, on the lateral side, we have the radial collateral ligament, which will serve to kind of create or resist varus forces at the elbow, has an attachment to that lateral epicondyle, comes down and has kind of an attachment to the most proximal portion of the radial head. And then we have this ligament here. This is known as the radial ulnar collateral ligament. Say that again, right, Dr. Cosby? So it has an attachment to the lateral epicondyle, but then it comes down and then attaches right here on the ulna. So it's kind of the connecting piece between the medial side and the lateral side of the elbow. Does that remind you of two ligaments in the knee? Great. If you said like the ligaments of Risberg and Humphreys, like you'd be correct, right? Similarly, this radial ulnar collateral ligament will do that as well. So again, we can see the kind of interwovenness of the lateral kind of ligament. So we have that radial collateral ligament, right? mostly going to resist varus forces at the elbow. We have that annular ligament. As you can see, it's kind of wrapping around that radial head, keeping it in its position, right? Because what do we know about the ulna? Like, remember, it sits within the kind of trochlear groove here on the elbow, right? But then posteriorly, it also has something to keep it in its place. With the radius, the hard part is it's kind of suspended, right? Do you see it? Like, it's kind of almost like a free floating bone. And so it's that annular ligament that kind of keeps that radial head in its place, in its position, in articulation, right? With the capitellum of the humerus. So hopefully you all can see why we have that annular ligament and kind of why it exists. But these kind of, we'll say, we'll count them out loud. So one ligament here, right? The radial ulnar collateral ligament makes 2. We have the 3 bundles, right, of the UCL, that makes 5. And then if we were to add in there kind of that annular ligament, there are 6 ligamentous structures that are responsible for providing 50% of the stability at the elbow joint. Which of these is most often injured? Great. Hopefully you all said the ulnar collateral ligament, particularly the anterior bundle of the ulnar collateral ligament. I really and truly do love this image because it gives you kind of an anterior posterior view of the relationship between the ulna and the radius. And so I want to really draw your attention to this annular ligament, right? We can see how it's kind of slinging around the radial head, and then you can see it here, kind of has an attachment to that coronoid process of the ulna. Again, its major role is really to afford us the ability to move into supination and pronation without dislocating our radial head. So we can really truly see in this image how we can have a great appreciation for the annular ligament. Even though it doesn't get a lot of the credit, oftentimes, if we think about this, if we're doing like proximal, let's do it this way. If we're doing proximal elbow joint mobilizations, are you seeing that? Most often it's at the radial ulnar joint. Which ligament do you think, which muscles and ligaments do you think you're really working on to create laxity? Yeah, you got it. It's the annular ligament. Hopefully you're seeing that. One anatomical structure on this slide that was not on the previous slide is this structure right here known as the interosseous membrane. It is a connective-like tissue structure. And its major role is to kind of prevent axial loads from kind of going through the radius and the ulna. In other words, it'll kind of absorb the axial load and transmit them to the humerus, which is a larger bone, more equipped to kind of absorb most of the stressors, right? So oftentimes when we have like a Fuchs pathology where a patient is landing or falling on an outstretched hand, there's the axial load that might actually occur. We're thankful that most often we don't have radial and ulnar fractures because that interosseous membrane is going to absorb a lot of those forces and transmit them or transfer them to the humerus. So that's its major role. The other major role is it's going to kind of limit, right, the amount of supination pronation that a patient might have in the clinical setting. Now, some interesting things to note. The ulna and radial bones are different distally and proximally. So I'm going to give you an example. The radius is very thin or small or more narrow, but gets wider distally at the wrist, right? So we can see that here as it progresses and becomes what we call as the radial styloid, and we'll talk about that in the wrist and hand lecture. And then proximally, what we can say about the ulna is it's larger, thicker, more robust proximally. And as we move distally, you can see that it gets thinner as we progress and it becomes the ulnar styloid. So those are things to keep in mind. One of the reasons that the ulna has to be more thick and more robust, maybe more coarse, is because remember, what did we say at the elbow joint? We have flexion moments, right? But as we move into not this phase, but as we move into this phase, what is going to happen? Right? That olecranon process is going to do what? It's going to butt up against the posterior aspect, right, of the humerus. And then here we go. This is one of the beautiful things about the way that God created the human body, right, y'all? Like, right? Let's go deep right here. Think about this. If this were a thin bone, so if it were thinner proximally than distally, what would happen? What pathology would we have in extension moments? What will we see most often? Right? I hope you understand that we probably would see more stress fractures or fracturing of the olecranon process. But because it is thicker and denser proximally, we don't see that injury most often happening. Maybe the development of osteophytes most certainly, but we don't see fractures to the olecranon as often because of how thick and how coarse or how dense that bone actually is. All right, so now we're moving to the dynamic stabilizers of the elbow joint. And on this image, you have both your wrist flexors and your elbow flexors. So most proximally, you're going to have your biceps brachii and your brachialis. And both of these muscles are innervated by the musculocutaneous nerve. So like as we're thinking through kind of brachial plexus or nerves that kind of immunate the elbow and the wrist, it becomes important to know what muscles are innervated by which nerves, right? And then next what we have are the group of what we call our flexor pronators, starting most proximally with the pronator teres. You can see that here. All of these muscles that I'm going to refer to next have a proximal attachment to the medial epicondyle and our wrist flexors and elbow wrist flexors, and wrist pronators. So as we think through that, pronators teri, you have the flexor carpi radialis, you have the palmaris longus, and the flexor carpi ulnaris muscles in that flexor pronator group. Pronator teres is innervated, and the palmaris longus, both of those muscles are going to be innervated by the median nerve, as is the flexor carpi radialis. So that pronators teres, flexor carpi radialis, palmaris longus, all of those are innervated by the median nerve. But this flexor carpi ulnaris, because it moves, is more medial, and it's going to be supplied by the ulnar nerve. And so you have a mix of the biceps brachii, brachialis, which are innervated by the musculocutaneous nerve and serve really to kind of flex the elbow globally. Some researchers would suggest that the biceps brachii is an assister of wrist or forearm supination. So it does have that role. Then you have the muscles of the flexor pronator group, most of which are innervated by the median nerve. So you have that pronator teres, you have the flexor carpi radialis, and the palmaris longus, all being innervated by the median nerve. You have that flexor carpi ulnaris, obviously, which is more medial in nature and is going to be innervated by the ulnar nerve. Now, as we transect and reflect, go back to gross anatomy, right? So these are going to be more superficial layers. And so as we start to kind of reflect back the flexor pronator group, we have some deeper muscles, right? Those deeper muscles are known as the flexor digitorum superficialis and then the flexor digitorum profundus, right? The superficialis, as you remember, kind of has that distal attachment to the pip, right? And then the digitorum profundus has that kind of distal attachment to the dip, right? So that superficialis, which nerve do you think it's going to be innervated by? Great. If you said the median nerve, you would be correct. So it's going to be supplied by the median nerve, like the pronators teres, flexor carpi radialis, palmaris longus. And then what about the flexor digitorum profundus? Let's think through that a little tiny bit. So if it is the lateral slips of the flexor digitorum profundus, that is also going to be supplied by the median nerve. But if it's the most medial slips of that profundus, then it's actually going to be supplied by the ulnar nerve, right? Surprise, surprise, surprise. And then we have the muscle of the pronator quadratus. What do you think it is supplied by chance? This is a random one. How about I give you extra credit? So the first person to kind of send this to me to tell me what it's innervated by. It's not a nerve that we really talked about, but I would be interested to see what you all would say. And then we also have this muscle right here, which contributes to supinator, actually does most of the supination at the wrist, or controls most of the supination at the wrist, at least from a proximal perspective. It's called the supinator muscle, and it's innervated by the deep radial nerve, right? So we have biceps brachii, which is going to assist with supination, and you have the massive supinator, which is wakes up to actually supinate the actual wrist. All in all, we have several nerves that are innervating each of these different muscle groups, right? The biggest thing that we've talked about on this slide are the flexor pronator muscles, right? Pronator teres is going to contribute to pronation of the wrist, right? And then on the opposite side of that, we have the supinator, which is going to contribute to supination of the wrist. We have the flexor carpi radialis, palmaris longus, and pronator teres, which are all going to be innervated by that median nerve. The flexor carpi ulnaris, which is going to be innervated by the ulnar nerve, along with the kind of more medial slips of the flexor digitorum profundus. So you've got a lot of anatomy here rich in this slide that you're going to have to learn and own. And most certainly you should own all of the functions of each of these muscles because they all do different things at the elbow and the wrist. So I'm going to move forward to kind of the the dynamic stabilizers of the elbow, and we'll break it down a little bit further. So the elbow flexors are going to be the 3 Bs. We talked about them a little bit on this slide, but let's take it a little bit deeper. The brachialis is probably the one that is most known for most of the elbow flexion that we'll do at the elbow. It's active throughout the entire range of elbow flexion, and it really acts kind of like a joint compressor. So in other words, as you can see here, it's the deeper of the 2 muscles, and so it will kind of pull the humerus into a good stable position, right? Then next what we have is the brachioradialis. As the name implies, it is a 2-joint muscle. So it is going to attach to the humerus, but then have a distal attachment where? Where is it going to actually attach distally? Someone tell me. Great. I mean, in the name, it's going to attach to the radius. It is also a powerful elbow flexor, right? Probably doesn't get as much credit as it should, but it contributes to elbow flexion as well. And then of course the biceps brachii, right? That's the handsome muscle or the cute muscle. It's the muscle that we see. It's the muscle that we try to bulk up as much as possible. It's also going to be active in elbow flexion. So we have 3 kind of major contributors to elbow flexion. The brachialis, which probably is the least mentioned muscle of the 3. The brachioradialis, which is a 2-joint muscle. It crosses both the humerus and attaches to the radius. And then we have the biceps brachii. All 3 of these muscles should be assessed if you have limitations maybe in elbow flexion. And then I would be remiss to not at least talk about the elbow extensors, right? The major contributor to elbow extension is going to be, which one? The triceps brachii, right? Most of the literature that you read actually gives credit to the medial head, which is why it's so important in gross anatomy to dissect that, so you can see just how beefy and bulky that medial head of the triceps is. And then you get the anconeus, which is also another kind of dynamic stabilizer, kind of like the sister muscle, the brachialis, but is a dynamic stabilizer of the elbow in most positions of extension. The exception would be full extension, because in full extension it's on like a slack, for lack of better words. I don't think I mentioned this, but your brachioradialis along with the other elbow extensors are going to be innervated by the actual radial nerve, right? Because they're going to be either more lateral posterior or actually posterior. So they're going to be innervated by the radial nerve, which is extremely important when you're thinking about assessment, right? Because your brachialis and your biceps brachii, they're innervated by the musculocutaneous nerve. And so as you start to assess and go through your upper quarter screens, this can kind of be telltale signs of whether or not it's brachioradialis involvement or brachialis or biceps brachii. And we'll do some manual muscle tests. Different manual muscle tests to kind of tease in or tease out which muscle might actually be involved. So let's look at the muscles of the forearm, kind of with the really with the nerves that I've kind of named somewhat. So I'm just giving you an image here. This is superficial layer view, which means nothing has been transected or reflected, right? We have that biceps brachii, which we've kind of already talked about, is a major elbow flexor contributor to wrist supination as well. But one of the beautiful things that I kind of want you to see here is kind of how the nerves of the brachial plexus kind of start to break off or branch. And so you can obviously see here, we have the ulnar nerve. If we're really looking at this, this is the brachial nerve and then the brachial artery, right? On this side, we have the, what we call as the lateral antebrachial cutaneous nerve, hint. May have something to do with that extra credit, maybe, possibly. So we can kind of see some of the superficial nerves. Obviously, we're not deep enough to see median nerve, and this is an anterior view, so we're not going to see the radial nerve per se in this particular image. We can see how this is kind of the sweet spot, this elbow right here, kind of as we have that brachial artery coming down and into the cubital fossa. So when we start to talk about elbow dislocations, it will become extremely important that that's a medical emergency, because what we're really concerned about are the brachial artery nerve and the vein, which kind of cross over into this cubital fossa. But let's take a look. So on the medial side of the elbow, let's orient ourselves. This is going to be the medial epicondyle. We have the pronator teres, which is going to come off, right? And then from there, if we're going in order, the next muscle is going to be the flexor carpi radialis, which is going to start medially and end, it's going to end laterally kind of on the radius bone, right? Then if we're still going in order with flexor pronators, then the next muscle is going to be that kind of palmaris longus, and then you get the flexor carpi ulnaris. So as we start dreaming about innervations, it kind of makes sense that these muscles are going to be innervated by the median nerve. You can see they're kind of one package. And then you can see how that flexor carpi ulnaris kind of branches away from the muscle group as a whole, even though it's attached and it attaches to the same proximal attachment site. One of the things that we can see is that ulnar nerve is going to come down and it's going to innervate that flexor carpi ulnaris. And we know this as the flexor pronator group. Now, I haven't mentioned the extensor supinator group, but what muscles would be involved in the extensor supinator? Well, that's kind of a hard answer, right? We can go with the muscles that would attach to the lateral epicondyle, and that is going to include the one right here, so the extensor carpi radialis brevis, the extensor carpi radialis ulnaris, which is not on here, or extensor carpi ulnaris, which is not on here and not pictured, the extensor digiti minimi, which is also not pictured on here, and then the extensor digitorum muscle too, right? So those would be the major muscles that kind of attach to the lateral epicondyle and might cause, like, for example, some type of tendinosis or like a tennis elbow in your patient, right? But overall, one of the things that we can see is that we have lots of dynamic structures, right? Coming from the humerus and having distal attachments, or we have lots of dynamic structures attaching to the ulna, right, which would be your flexor pronators or your extensor supinators, right, attaching to the lateral epicondyle. All dynamic structures, but keep in mind they're not responsible necessarily for creating the stability about the elbow joint. So yes, they're extremely important to help create a dynamic joint, but they aren't the most important anatomical structures. Bony and ligamentous anatomy are going to be huge and are going to be key. Now, we're looking at this from a posterior perspective. The last slide was an anterior perspective. What we can see is the anconeus, which, remember, is a major extender except in the last few degrees of elbow extension, and is supplied by, what did we say? By the radial nerve, right? And so you can start to see some of the things that I talked about that attach to kind of that lateral epicondyle. I'm looking down because I'm looking down the slide. So you have that extensor kind of digitorum, right? And then we talked about the extensor digitorum minimi. So these are all muscles that'll come up and kind of have an attachment proximally to that lateral epicondyle. And then on this side, again, what we're really truly just looking at are the deep muscles, right? So there's that supinator, which we talked about. It's going to be extremely important in contributing to what? Elbow supination. And what do we see poking through that supinator, right? The radial nerve. What's beautiful about the anatomy and why it's so important in the elbow in particular when we have a dislocation or a subluxation is the amount of arterial structures that kind of cross the actual elbow joint. Again, making it extremely important for patients who have an elbow dislocation to get seen right away to kind of make sure that nothing gets entrapped in the actual elbow itself. So that ends the anatomy lecture. Hopefully that was pretty helpful. We'll kind of go through things in class as well, and then we'll move into injuries of the elbow joint. So thank you for sticking with me thus far. Part 2 coming up right now.